great session of about acute respiratory distress syndrome to be delivered by our Dr. Priteema Chanana, who is presently working as a senior consultant in critical care department, Sir H.N. Reliance Hospital, Mumbai. After completing her anesthesiology, she had been aged in IDCCM and IFCCN. Not only that, hello. And not only that, she had aged in ECMO specialty also. So I guess once she join us in, we'll start the session. Yes, Dr. Priteema, you can start now.
Ma'am, please unmute.
Yes. Yes, ma'am, you can start now. Not audible, ma'am.
You are not audible.
Dr. Apoorva?
Yes, ma'am, now you are audible. Please continue.
Am I audible? Okay.
Yes, yes, clearly.
Not working. I'm working on the speaker and my speaker is not very good. Anyway, so that is, I will get disturbance because of my speaker, but I think you will hear properly. So that's
Absolutely.
okay. We tolerate
Okay.
my laptop.
It's okay, ma'am. Please continue.
Yeah, so let us start. So my screen visible?
Yes,
Yes, ma'am.
clearly.
So, good afternoon, everyone. So, today the topic of discussion is acute respiratory distress syndrome. This is, I don't know how to start and how to finish because this is very, very difficult and very vast topic for even for the doctors. And I really thought a lot and struggle a lot that how much information I should pass on for the our nursing team. But yes, because we are doing this IDCCN course, so we should be aware about the little basic idea about the acute respiratory distress syndrome. So I will not go into the very, vast and very detailed discussion about the ARDS, which we used to do, right? Trials and everything, because I don't think that is that much important for you. But because of that trials, whatever the information we have, whatever the practice we have in day-to-day practice, we will discuss about it. So this is the definition of 2012. The definition was given by this Berlin definition of ARDS. This is the most famous and most used definition. If I go into this definition, it is an acute diffuse inflammatory lung disease leading to increased pulmonary vascular permeability, increased lung weight, and loss of aerated lung tissue with hypoxemia and bilateral radiographic opacities associated with increased venous admixture, increased physiological dead space, and increased lung compliance. Oh my God, this is a huge sentence, and this is, I believe that this is very difficult to remember word to word for me as well. So let try to break it up. Just एक स्लाइड मूव हुआ, उसके बाद दूसरा स्लाइड मूव नहीं हो रहा है. अजीब है यार.
It's okay, ma'am. Take your time.
Yeah, but these laptops, they always pass on test. But when we actually deliver the lecture, it always fails.
मैम मुझे मेल कर दीजिए, मैं शेयर करती हूँ.
Yeah, I can try that. It's not visible only. Let me try to mail you, Deepa. Or maybe I can drop a WhatsApp also. Is that okay?
Yes, yes.
So, okay, do you have your mail ID in your hand, Deepa?
Please WhatsApp me. I can share it.
Okay. Give me 5 minutes. I will be back. I think you can continue for 5 minutes.
Yeah, sure.
Yeah, please. Thank you so much.
That's
And
okay.
you
That's
can
okay.
at least give on the basic information to the nurses because they are
Right.
on. And I will join back in 5 minutes.
All right. So all my nursing friends, we all are well aware of this terminology, acute respiratory distress syndrome. Here or there, today, tomorrow, yesterday, we all have heard about it in our working environment, I'm sure. So if anybody like to give a simpler definition of what we just had read and what we are reading right now on our screen, can somebody take an attempt and can write in the chat or can raise the hand? We have Chandrama, Ditimol, Lori Nayak, Sajita, Simoli, T. Lavanya. Anybody? I guess chat is disabled. Deepa, can we just allow them to write? Lori, please. Great. You can unmute and speak, Miss Lori. Deepa, can we allow it?
Yes, sir.
Yeah. Please speak.
Good afternoon, sir.
Yes, yes. Now you're audible. Please speak.
Yes. Sir.
Don't be afraid. Don't be shy. You have taken an honest attempt. Just take it.
Yes, sir. Sir, good afternoon, sir.
Good afternoon.
Sir, when you are joining, sir?
Sorry.
When you are back, ma'am, back for class?
In 5 minutes. She's just arranging her slides and all. Okay,
Yes,
you
sir.
wanted to ask that. I thought you will be interested in answering what actually ARDS means to you guys.
Yes, sir.
Yeah, please tell me.
Sir, ARDS means acute respiratory distress syndrome.
Good.
Where the lung injury is
Perfect.
lungs opacity is increased and
Right.
pulmonary velocity also is increased.
Right.
In COPD, patient was actually air hunger. Then
Mm-hmm.
we can administer the oxygen maximum 2 to 4 liter and target
Okay.
saturation we can do the 90 to 92%.
Excellent. Excellent. What else I can expect from you guys? You had said all the things which we are going to discuss in further slides. Ma'am is going to demonstrate to you everything over here.
Yes, sir.
Thanks a lot, Laurie. You can mute your mic, please.
Yes, sir.
Great.
Thank you, sir.
So as she had spoken about everything, and now I guess ma'am is ready with the slides. So she'll start any moment.
Yes, sir.
Dr. Priteema, you can start.
So I think now I think I can have a uninterrupted class. Okay, so the definition is very elaborated, and it has lot of heavy words, and it's a big sentence. It is definitely difficult to remember. So go back to this. Yeah, next slide. Yeah, so this is the basically a chart which actually have broken that definition into the 4 points, four important points, the Berlin definition of ARDS. So the four important component of ARDS are: first is the timing of the disease or timing of the insult. It should be within 1 week of any known clinical insult or any new or worsening respiratory symptoms. So what are the symptoms patient is having, like hypoxemia? These symptoms should be within 1 week. So that will fulfill your criteria of ARDS. So what are the findings are that patient is having respiratory distress, patient is having hypoxemia, the saturation of around 90%, and PO2 of around 65%. But the duration of this illness is less than 7 days. Now, what is the next component to confirm to go for the thinking of ARDS? So, hypoxemia will give you the idea of ARDS, and the timing will elaborate you to the further questions. Second thing, you will look for the chest imaging. The chest imaging, the Berlin definition have shown that there is a bilateral opacities visible on either the chest X-ray or the CT scan, which is not fully explained by the either effusion or any collapse or any nodule. So there are some infiltrate into the bilateral lung fields, which
Ma'am, please adjust your audio. We are not uh, having you clear over here.
Ma'am, please do one thing. Off your camera.
Till she is readjusting, we all can have a look over the slide which is presented right in front of us. I guess all must have gone through this slide. If yes, then there are myriads of reasons of why a person lands in either pneumonia, respiratory distress, or any sort of dyspnea. So to clearly have a demarcation line and stating, defining what ARDS actually is, these societies had made a definition, Berlin definition, then modified Berlin definition, revised Berlin definition, all were there to guide us through what exactly we are dealing with. So first important thing is this timing, that it should be the initiation of this ARDS when we tag it as that this initiation should be within 1 week of insult. I guess ma'am is online. We'll continue.
Yeah. Am I audible now?
Yes, ma'am.
Yeah. Okay. So the third part is the origin of edema. So whatever the infiltrates are visible on the chest X-ray or the CT scan, there should not be any explanation related to the cardiogenic pulmonary edema, because whatever the picture is there, it may be cardiogenic or it may be non-cardiogenic. Just to confirm that this is non-cardiogenic, initially the presentation they used to confirm with the Swan-Ganz catheter. They used to put a Swan-Ganz catheter. They used to check the pulmonary capillary wedge pressure. If this pressure is less than 80, that rule out some cardiology reason for this kind of edema. So we should rule out that there is no relevance to the cardiologic etiology. So if it is ruled out, definitely there is a problem with the lung only. Now the fourth thing is oxygenation part. As I mentioned that there is some desaturation or hypoxemia and the PO2s are around 65 or something. But can I make a diagnosis on that ARDS? Yes, there is a ARDS, but we should decide about the degree of ARDS, how severe this is. So divided into the three parts, mild, moderate and severe. How you will diagnose that mild? So we will check with the PF ratios. What is PF ratio? PaO2 divided by FiO2. FiO2 which we are giving on the ventilator support or maybe the CPAP mode or maybe the NIV, or now we are including HFNC also, we will discuss in the next slide. So FiO2 is, suppose we are giving around 60% of FiO2 and in ABG PO2s are around 90. So 90 divided by 0.6. So that will give you the figure of around 150, right? So this is your PF ratio. So the range of PF ratio will give you the idea the how severe your ARDS is. So if PF ratio is between 200 to 300 with a PEEP or CPAP of more than 5, it is classified as a mild ARDS. If the ratio is between 100 to 200 with a PEEP of more than 5, it is moderate. And but if PF ratio is less than 100 with the PEEP of more than 5, that will give you the idea that it is a severe ARDS. Now, what are the shortcomings in these 4 points? We have included the chest X-ray and CT scan. Sometimes there is no bilateral infiltrates on the X-ray. X-ray will show you that this is fine. I'm okay with that. But CT will give you the better idea about the infiltrates in the lung. But each and every organization doesn't have the facility of the CT scan. In that situation, just looking at the X-ray, no infiltrate, timing is okay, PF ratios are low, which is giving you the idea this is maybe ARDS, but X-ray is looking quite okay. So what you can do here, you can use ultrasound machine, which has come into the global definition of ARDS. If you're doing an ultrasound with the expert sonologist, If there are B lines or there is some pleural layer damage, you can see if it is visible on the ultrasound, you can say that my lungs are not looking good. That means there are some ARDS picture. Now, what is the second thing which is missing? We have included a CPAP or PEEP of more than 5, which is giving you idea of either you are using the NIV or patient is on mechanical ventilation. But what if patient is on HFNC? Suppose patient is on HFNC, but the PF ratios are around 150 or something. So should we include these kind of patients to ARDS? Yes, you can include these patients. Deepa, next slide. Yeah, next. So just to simplify that, so first definition you have seen that there is a paragraph of definition. There is a one sentence which is into the one paragraph. Now we have break into the 4 components that Berlin definition, timing, in back, Deepa. Yeah. So these are the definitions which is given by the Berlin. There are 4 criterias. To more simplify, to just to memorize that. What are 4 component of this Berlin definition? So ARDS itself give you all the 4 component. A is acute hypoxemia. The duration should be less than 1 week. R stands for ratio, that you have to look into the PF ratio, that PO2 and FiO2. D is the diffuse bilateral infiltrates. That will give you the third picture. And Sean, I'm using Sean because in the past we were using Sean, but nowadays we are not putting patient PA catheter for just to understand cardiology or non-cardiologic thing. We are doing echo because nowadays we are very well equipped with the sonography machine in the ICU. We are scanning the patient, we are scanning lung scanning, even echocardiography. We are getting better idea about the etiology with the help of focus. So based on these 4 points, we are defining the ARDS. Next slide. Yeah, so this is the new which has come up in 2023. This is the global definition of ARDS. So what is missing in the Berlin definition? This is the global definition. One point I already mentioned, that radiological feature. Suppose the patient that particular center is not equipped with the CT scan in house, they have to send the patient to some nearby radiology department or nearby some center to do a CT scan, and patient is not stable enough to mobilize. In that situation, you can do a lung ultrasound by a trained professional, and we can get some idea that if the lungs are having infiltrates or not. Second thing is hypoxemia, which I already mentioned. Mild, moderate, and severe. These grading is dependent on the NIV or the CPAP. That means the patient is on mechanical ventilation. But if patient is on HFNO and patient is requiring more than 30 liter per minute of oxygen support, in that situation, you can again include these patients into the mild criteria. You can take that FiO2 and PO2, and based on that, you can decide that these patients have ARDS or not. Usually, we prefer HFNC for the mild patient, mild ARDS only. For moderate and severe, we prefer for the mechanical ventilation. We are not waiting that patient can sustain for HFNO. We were not, yes, but in COVID scenario, we have done that also. But normally, we are not doing that. Now, the third missing part in the Berlin definition was, if we don't have arterial line in place and we want to diagnose, we want to confirm that this patient is having significant hypoxemia. In that situation, we can take SpO2 and FiO2 ratio. In place of PaO2, you can take SpO2 that you have in your hand. You can see the pulse oximetry. If your saturation is showing 90% or 88%, you can take that figure and divide by the FiO2. If your SF ratio is less than 315, with the SpO2 of less than 97%, that means that patient is having ARDS. So this is the new points which have included into the global definition, which was missing in the Berlin definition. So the day by day, we are improvising and making changes into the definitions for our better understanding and for the early diagnosis. Yeah, next. So this is the chart which is showing over a period of time what changes we have made. In 1994, there was some criteria, but it was not having that PEEP criteria. PEEP was not specified in that criteria, but in Berlin definition, we have included that one. So in 2012, we have decent definition of Berlin, which we have already discussed, but 2-3 points were missing, which they have included into 2023 into the global definition, which is ultrasound, SpO2 and FiO2 ratio, and HFNC involvement. So this is the over a period of time we are developing and we are making the things easy and comfortable for the practicing physicians. Next. So based on that, I'm just going to describe one by one the patient description. The first patient is 68-year-old male with a abnormal sepsis, septic shock, and the acute hypoxemic respiratory failure. And so your patient is giving you idea that this is the acute changes because of the sepsis, and patient is having some respiratory failure and hypoxemia. That is the first thing which will give you signal in your mind, is it ARDS? Now go for the imaging. You can see the X-ray showing bilateral infiltrates, which is giving you idea that yes, my chest X-ray is also bad. Now you will look into the PF ratios. Your patient is mechanical ventilated. You can see the tube in place, and FiO2 is 0.5 with a PO2 of 75, and which is giving you the PF ratio of 150. So which comes into moderate ARDS picture. So this criteria that intubated ARDS severity is moderate, and typically patient is included in the Berlin definition. So this is fitting into the classical Berlin definition. So your patient is having moderate ARDS. Now we'll go to the second patient. Now the second patient is on HFNO. The Berlin definition doesn't have the HFNO criteria. So 54-year-old female with a history of breast cancer, COVID-19 pneumonia, with a worsening shortness of breath with the past 6 days. Acute, less than 7 days, it's acute presentation. Now we'll go for the imaging. Imaging is showing bilateral infiltrates. Again, the second criteria fulfilled. Now, if we are going by the Berlin definition, so we will get stuck here because we don't have the PF ratio idea on the HFNO. But in this case, if we apply for the global definition, we do have the criteria. So HFNO is 40 liter per minute, which is definitely more than 30 liter, and FiO2 is 80%. Saturation is 91%. Now again, the third thing, we don't have the ABG, but we have the SF ratio values, which is 114, which is significantly less. So this also fulfill the criteria of ARDS. So based on that, we can see that how the modification in the definition is helping you to understand the criteria of ARDS. Next. So this slide looks very, dangerous and well occupied, but I think we should discuss this slide in detail. So just ignore the right-hand side. We will discuss about the normal alveolar capillary barrier first, just to understand the pathophysiology of the ARDS. Now, whatever the gas exchange happen. So if we think about the lung, just imagine about the alveoli. One alveoli, which is surrounding by the capillaries or membranes or some interstitial space. So one alveoli membrane, and surrounding to that, if you see, there is a interstitial space, and outside that there is a capillaries. So everything is looking beautiful, normal, and everything. Now, what are the things which are making this thing beautiful and safe? If you talk about the alveoli, just upside, if you see that this yellow line, this is the epithelial cell of the alveoli, and you can see just up the epithelial cells. This looks pinkish, which looks that air space is absolutely dry. Now, if you talk about this epithelial cells, if you see, there are two kinds of cells, type 1 epithelial cells and type 2 epithelial cells. If you understand this anatomy or this cell line structure nicely, you will understand the pathophysiology of ARDS very nicely. So there are type 1 cells and type 2 cells. If you see, these cells are very closely adherent to each other. There is no gap, and it is smooth. And there are some some glycocalyx, which you can see, these are the threads. You can see on the inner side of the epithelial cells. These are also uniformly placed, and they are looking very healthy. So this is the normal epithelial cells, type 1 epithelial cells and type 2 epithelial cells. Type 1 epithelial cells, I have specification, they are closely adherent to each other. There is no gap between two cells. And there are in between type 2 cells, which are cuboidal cells. What is the main function of type 2 epithelial cells? They make actually the surfactant. If we have read science in the school, we have understood that importance of the surfactant. What does surfactant do? Surfactant keep that cavity into that particular shape. And if there is a surfactant adequately available, there is a surface tension will be low, and that structure will be uniform, and that will stay into some particular shape for a certain period of time if we have adequate surfactant in place. Now we talk about the next space, which is also little dark pinkish, but this is the interstitial space, which is between the epithelial cells and the endothelial cells. Endothelial cells are basically into the capillaries. So this is the capillary, which you can see there is a endothelium, which is uniformly, endothelial cells which are uniformly connected to each other. There is no gap in between. There are some RBCs flowing smoothly. There are WBCs flowing smoothly, and platelets. Nothing is adherent to each other. They are flowing very smoothly into the capillaries. And there are some channels, sodium potassium channels, through which the electrolyte exchange and this thing is happening very smoothly. So this is a healthy alveoli. If you see, the air space is dry, intact epithelial tight junctions, intact epithelial glycocalyx, normal surfactant production, and the sodium chloride transport is also smooth. And what about the normal endothelium? Intact endothelial tight junctions, intact endothelial glycocalyx also, no adhesion molecules, and even all the cells are flowing smoothly into the capillaries. This is the normal cell. Now we will understand about the ARDS. What will happen? Now, how the damage will start. So in mild injury, now first the things will start these type 1 cells. If you see these epithelial cells as well as the endothelial cells, if you see there is a gap between two cells. If you see closely, initially there was no gap into the healthy cells, but in the damaged cell there is a gap because of some direct injury or indirect injury. There is a mild edema formation, so gap is generating between two cells, and that is allowing some fluid shifting from the capillaries to the alveoli. So if you see there is a blue color fluid into the alveoli, so fluid is coming from the capillaries, which already started flowing. So the mild edema formation, there is a disruption of the tight junction, and there is a decreased surfactant production, which is actually happening through the help of type 2 epithelial cells, but that is also damaged. So there is a less of surfactant production. So that will create a, there will be surface tension will be high, and the capillary will try to collapse. So few alveoli are filled with the fluid, and the remaining space is trying to collapse. So whatever the size of alveoli we were having initially, that will be little narrow, and that will be little shrunken, and remaining part is also filled with the fluid. And what that fluid will contain? These capillaries will leak fluid, little proteinaceous fluid, little proteins, even the damaged RBC will also go into the alveoli, and WBC will also start, entering into the tight junction into the alveoli. So these combination of fluid will create some, dirty material into the alveoli, which will not allow the gas exchange to happen through these capillaries or through epithelial and endothelial cells. So that will hamper your gas exchange. So what will happen if there is a disturbance in the gas exchange? There will be some hypoxemia. Whenever there is a hypoxemia, suppose the patient is having 100% of saturation, and after some time there is some direct or indirect injury to the lung, and there is a little drop in the oxygen level. Now, how the body will react to it? The body will react that there will be little increase in respiratory rate. That patient will start breathing little rapidly, because every organ needs oxygen. If we are not getting enough oxygen, we will try to compensate with the respiratory rate. So there will be little increased work of breathing. There will be increased respiratory rate that will start happening. And in severe injury, yes, this damage will be more. There will be some, these cells will be almost necrosed. This glycocalyx will also fragmented and disturbed. So all the protective mechanism of the alveoli, the surfactant, the glycocalyx, the tight junctions of the epithelial and endothelial cells, this all will get disturbed because of some inflammatory reaction or some direct injury to the alveoli. So that will create some fluid accumulation to the alveoli. The alveoli will be flooded with the fluid, WBC and platelet and everything. And surfactant will get lost. So in that situation, alveoli will collapse, and there will be no gas exchange happening. And because of hypoxia, again, the respiratory rate will increase, work of breathing will increase, and then patient will develop ARDS. And these pictures will be visible in the imaging. There will be a PF ratio, there will be some shunt, some pulmonary shunt will happen, because this area in the mild injury, the blood flow is adequate, but gas exchange will not happen because of the damage and there fluid accumulation to the alveoli. In that situation, the shunting will happen because this area is getting enough perfusion, enough blood flow, but the alveoli is not intact to allow the gas exchange to happen. So this pathology, if you understand, then you can understand that how the ARDS is happening and how we can treat it. Next slide. So once, whatever I discussed about the pathophysiology, that was the actually when there is a fluid leak into the alveoli, there is a WBC and everything. So this is classically the exudative phase. In alveolar epithelial cells, that the type 1 pneumocytes and the type 2 because of loss of surfactant, and there is a capillary epithelial cell damage. Because of that, there is an injured alveolar capillary barrier, increased permeability, edema fluid accumulation to the alveoli, and there are some cytokines or inflammatory cells also will get into the system. So there will be reduced space for the gas exchange. Breathing will be definitely difficult because these alveoli are quite heavy. The alveoli which filled with the air, now alveoli are filled with the fluid and dirty, this thing. So in that situation, the breathing will be quite heavy. So patient will have breathing difficulties and patient will require some assistance for the ventilation, because some point that they can breathe, they can increase the respiratory rate, there will be increased work of breathing, but continuous increased work of breathing, the patient will tired out. In that situation, they will need some assistance for the ventilation. So we always try or start with the HFNC first or NIV. If still not able to maintain, we have to go for the mechanical ventilation. So exudative phase basically sustained for the first 7 days. The patient do have exudative phase. In that situation, if we address the situation, we have to first find out the reason for this ARDS. If we try to address and we can stop this exudative phase here only, that patient will start recovering. But if more than 7 days the things are not settling, the patient will go into the proliferative phase. The proliferation of type 2 cell in this situation with the treatment and all, that these cells will start regenerate, the type 2 cells and type 1 cells, and they will try to sort out the situation. That lymphatic drainage of the edema fluid will start. There will be type 2 cells and type 1 cells. Type 2 cell will differentiate into the type 1 cells. They will start working like a normal. They will start producing surfactant. They will try to make a barrier between the capillaries, interstitial space, and the alveoli. And they will stop further fluid to enter into the alveoli. In that situation, this is the basically a recovery phase. Most patients will recover in this phase. But if it is not settling within 14 days, patient will go into the fibrotic phase. That very few patients usually progress into the fibrotic phase if we are not able to tackle the situation on time. There will be fibroblast proliferation because continuous damage to these alveolar cells and will convert these cells into the this rigid structure that will create into the fibrotic stage, and that fibrosis will limit your recovery in a longer duration, as well as you will depend on the ventilator because patient will have increased work of breathing most of the time. When we will try to wean from the ventilator or the NIV or HFNC, the patient may not be able to tolerate that. In that situation, ventilator dependency can come. That is the worst situation which we have faced in COVID. I think most of the patient develop fibrotic phase because in COVID we have one irony of the situation that there was some hypoxia. The patient was hypoxic but not symptomatic for a longer duration. So usually patient present in a, I would say that in a little bit of later exudative phase or the proliferative phase, which patient have not given us the good window to treat that. So patient already presenting to us after 10 days or this and immediately going into the fibrotic phase without giving us time to manage the situation. And these patients, when going to the ventilator, they don't go good with the mechanical ventilation as well. And even proning did not help that much. Even the last resort, ECMO. also didn't help because ECMO always help in a reversible situation. In fibrotic lung disease, this is kind of irreversible situation, and that ECMO and any therapy is not helping much. So that is the situation that we have faced in COVID, which was actually a hard time for us. Next. Next. Yeah. So now how will we understand that what are the causes of this? Now this is the inflammatory reaction to the alveoli or the capillary endothelial cells. But what is the reason for that? The reason either there is a direct injury or the indirect injury. How the direct injury will happen? The direct injury, each and every direct injury will help with the inhalation, whatever the through the airway. So direct injury, either you can have a pneumonia, either it's a viral pneumonia or the bacterial pneumonia, or some near drowning situation, or maybe some aspiration if the gastric content going into the lung. Definitely, the alveoli are not used to have that much of acidic environment. So cell will get damaged immediately, and then inflammation will start. Or maybe the blunt trauma, and there is a toxic inhalation injury, or if patient is trapped into the burn building or something, and there is smoke inhalation. These can also create damage to the alveoli. And because of that damage, the process will start, which we have already discussed in pathophysiology. But indirect injury, there is nothing coming through the inhalation, no smoke, no aspiration, or these things. But there is some systemic reaction into the system, which is creating damage at the capillary level, endothelial level, and that will create a cytokine storm kind of situation in which these capillaries become leaky, there are damage to the endothelial cells, and the fluid will leak into the alveoli. This is kind of indirect injury. What are the situations where we can have like any sepsis, which is the most common cause of indirect injury to the lung, indirect injury for the indirect reason for the ARDS, pancreatitis, or maybe multiple blood transfusion, which usually we used to call as a trolley kind of stuff, fat embolism, or amniotic fluid embolism. These kind of things can create some storm or some inflammatory reaction into the system or systemic system. Because of that, the alveoli are getting damaged. There is no direct injury to the alveoli, but yes, there is an indirect changes into the capillary endothelial membrane, and because of that, alveoli are getting flooded. Next. Yeah. So we're coming to the diagnostic approach. So how you will diagnose these kind of situation whenever there is a patient for hypoxia. So first you will get an ABG. Next. Yeah, so there is acute hypoxemia. That is the first criteria, which is less than 1 week. And once we have confirmed this acute hypoxemia, we will do the ABG. In arterial blood gas, we will see the PF ratio. If the PF ratios are less than 300, which is giving us the diagnosis of the ARDS. Now we will go for the grading of ARDS. A PF ratio between 200 to 300, it is a mild ARDS. 100 to 200 moderate, and less than 100 is severe. Now we have confirmed with the ABG that there is ARDS. We will go for the AA gradient or the normal PCO2. If it is showing the normal PCO2, but there is a significant hypoxemia, go for imaging, chest X-ray or the HRCT. But in the global definition, we can do even bedside ultrasound also, which will give you some idea about the infiltrates or pleural irregularity, or there are B lines and all. So which will give you the idea, and 2D echo, which will give you the idea of ejection fraction, LV and diastolic pressure, or with the help of Schwann-Ganz, you can have the pulmonary capillary wedge pressure, which is less than 18, which will give you the idea that this is non-cardiogenic edema. And with the pulmonary infiltrates, echo, again the PF ratio and acute picture. So this is the stepwise diagnostic approach. You can make a diagnosis that my patient is having mild, moderate, or severe ARDS, and which is not relevant to the cardiology thing. Next. So whenever there is a hypoxemia, so what are the changes are happening? Why we are so much worried about the ARDS? Why the ARDS patients are going into the multi-organ dysfunction, what is the etiology and what is the pathophysiology to that. Whenever there is a hypoxia, the oxygen level are less because of there is no good gas exchange at the alveolar level, capillary alveolar level. So in that situation, O2 will drop into the blood. Because of the hypoxemia or less O2 going into the pulmonary circulation, which will cause a pulmonary vasoconstriction. Because of the hypoxemia, longer hypoxemia, there will be a pulmonary vasoconstriction, and because of the vasoconstriction, definitely the resistance of these vessels will increase. That will create increased pulmonary vascular resistance, and because of that, the patient will have a pulmonary hypertension. Whenever there is an increase in PVR due to the back pressure, the RV pressure and the RA pressure will also increase. And how the RA pressure will reflect? RA pressure will reflect there will be increased CVP as well as increased JVP. And because of all these things, because the right heart pressures are high, because of that, there will be hepatomegaly, there can be ascites, there can be pulmonary edema. And once there is a chronic RV dysfunction, that will reflect on your left side of the heart also because of the hypoxemia. So that is the situation. Then when one by one, all the organs are getting involved just because of the hypoxemia at the alveoli level. So that is creating a multi-organ dysfunction thing. So we have to address the kind of situation as early as possible. The first and foremost target for us is correct the hypoxemia, because pulmonary hypertension, hepatomegaly, ascites, pedal edema, hypotension, these all are related to hypoxemia. The first and foremost target is you have to address hypoxemia. Next. Yeah, so treatment approach. Next. So this is a slide which is giving you some idea about how you will approach these kind of patients. You have diagnosed ARDS, now you know this is mild, moderate, and severe. So don't think twice about the moderate and severe ARDS. If we have PF of less than 200, you can give little bit of trial of NIV or HFNC, but prefer to go for the ventilation. But more than 200 PF ratio, you can try on NIV and HFNC. You can work on that. You can try to treat the etiological factors. What is the reason for that? If things are manageable with the NIV or HFNC, you can continue with that. But less than 200, go for mechanical ventilation. Mechanical ventilation, the recommended is low tidal volume ventilation and the higher PEEP. So how you will decide that, we will discuss in the next slide. If there is a PF ratio of less than 150, low tidal volume, higher PEEP, in this situation, you can add on deep sedation and neuromuscular blocking. If still it is not helping despite your higher PEEP, low tidal volume, and neuromuscular blockage, everything is done, still you are not able to achieve the PF ratio of more than 150, you can try on the prone position. So prone ventilation will help us for a better gas exchange. And because of the low tidal volume thing, because you are addressing mainly the hypoxemia. Whenever we are trying to correct the hypoxemia, there is a one negative impact of that is there will be a rise in CO2 level. You will have some hypercapnia into the system. And to address that, we will ignore some kind of CO2 for some time, which is called as like permissive hypercapnia. That will decide on the pH that we will discuss in the ventilation slides, a ventilation topic. But permissive hypercapnia, definitely you can allow some kind of CO2 to accumulate, but if it is going beyond less than 7.2 or 7.15, you have to address that situation. Because low tidal volume, higher PEEP, and prone positioning, these all three things will increase your CO2 level into the blood. To address that, you may think of it is, if it is not manageable with the ventilator settings or optimizing of ventilation, you can try for the ECOR. ECOR is extracorporeal CO2 removal. In that, you will put one HD catheter into the IJV and you can use a filter to remove the CO2 extracorporeal. Extracorporeal means outside the body. So outside the body, you will remove the CO2, rest of the things lungs will take care, because hypoxemia is not a major issue. With the low tidal volume and the prone positioning, it's helping in achieving some good PF ratio, but it is not helping in CO2 removal. In that situation, you can put the patient on ECOR. But as per the evidence, till today, ECOR has not given a very good beneficial outcome. So we are not using in day-to-day practices. Even I am against ECOR till today. Maybe in future, if something come up, we may try. But till today, I'm not in a favor of ECOR at all. Now, if the PF ratio is less than 100, again the same thing, low tidal volume, high PEEP, neuromuscular blockade, prone, everything we have tried. Now we have to think of the other options. Still, we are not able to achieve good PF ratio. There is a pulmonary hypertension feature. So we can try with the inhaled nitric oxide. Although there is no evidence-based benefit or mortality benefit with the inhaled nitric oxide, but we can try if options are out of this thing. Second thing, high frequency oscillatory ventilation. I think nowadays nobody is using it. In the past, when I was student, I think in 2015 or something, we were still having HFNO in the HFOV in ICU. I have seen one or two patients treating with the HFOV. It is not easy machine. If you put one patient on HFOV, there will be a lot of sound in ICU, number one, and we don't know how much it is helping. So till today, there is no evidence-based benefit or mortality or morbidity benefit with the HFOV. So we are not using. I think, I don't know if Dr. Apoorva, you guys are using. We are not using at all. I think I have not seen the machine since last 5 years.
Okay, ma'am.
Yeah. Next is ECMO, extracorporeal membrane oxygenator. So that is the last resort that we will discuss in the next slide. So now how will you manage these kind of patients? The first and foremost thing is, whenever you have a ARDS, bilateral pulmonary infiltrate, in these kind of patients, you will try to avoid any pulmonary edema or any cardiology component or any fluid overload, because your lungs are already flooded, already compromised, because alveoli are filled with the fluid. In that situation, you will not increase fluid into the interstitial space because gas exchange is already hampered. So little fluid added to the lung will worsen your situation. In that situation, the fluid conservative strategy is recommended. So always aim for the euvolemia. Next and most important thing is mechanical ventilation. How you will ventilate these kind of situations. So recommended is low tidal volume, as low as you can do. Why the low tidal volume is recommended? We actually use treat these kind of lung as a baby lung ventilation. Why it is called as baby lung? Because I have seen shown you the pathophysiology picture that alveoli, half of the alveoli are flooded with the fluid. So this part is not participating in the gas exchange, and because of the surfactant loss, the size of the alveoli has also reduced. So very, very small part of the alveoli are contributing into the gas exchange. So healthy part, suppose your 50% of the alveoli are flooded and they are not participating in gas exchange, remaining is 50%. So in 50%, if you ventilate this 50% of alveoli as a normal lung or normal healthy adult lung, what will happen? There will be volume trauma because there is no space for air to go in and redistribute the gas into the alveoli. In that situation, if you're giving a normal tidal volume or normal volume of the air into the lung will have volutroma. What is volutroma? When there is a lot of air you have pushed into the alveoli and compliance is poor because of the interstitial edema. In that situation, that volutroma will stretch into the alveoli and it will rupture, and that can create some ventricular induced lung injury as well, because the lining of the alveoli will get damaged because of the high volume, or because of high volume there may be pressure increase also. It can create barotrauma also. So you have to prevent ventricular induced lung injury. So baby lung ventilation is recommended in this situation. So we prefer to give less than 6 ml per kg of tidal volume. Tidal volume is based on the weight. Which weight? It is a predicted body weight. As per the height of the patient, we predict the weight of the patient and we decide about the total tidal volume for that certain patient. And we always give high PEEP. So how the PEEP is helping? So PEEP is positive and expiratory pressure. In that situation, how it is helping? It is trying to keep the alveoli open for a longer time, for the certain period, or for to sustainable situation actually. So repeatedly, if we are giving less PEEP with a loss of surfactant, what will happen? The alveoli will open up and it will collapse again because there is no surfactant. So in that situation, the opening and closing of alveoli will create some trauma to these alveoli. It is called as atelectotrauma. So we want to avoid this. So in that situation, we will give certain PEEP to keep the alveoli open even at the time of expiration also. Longer the alveoli will happen, and the longer the gas exchange will happen. So the some gas exchange will happen at the time of expiration also because we are keeping the alveoli open. So the main target for all these things is correct the hypoxemia. There should be some gas exchange, some O2 oxygen get into the system. So decrease tidal volume and increase PEEP is recommended. Decreased tidal volume will help in decrease in ventilator-induced lung injury, and they have documented decreased mortality after using this therapy. Increased PEEP will decrease the atelectotrauma, and again mortality will decrease. Now, next slide. Next. So how you will start with the ventilation? So we have discussed about the fluid restrictive conservative strategy. Now we will talk about the ventilation in detail. Little bit, not in detail. Ventilation in ARDS is a completely a huge topic. So first of all, when we are putting a patient on ventilation, so how you will put your patient on ventilation? What are the main things you will look into it? First and foremost thing, these patients will get ventilated by the controlled mechanical ventilation. Control, either it's a volume control or the pressure control, the choice is yours. We can't say which mode for this kind of patient is good. I feel, or even the most of the people are says ventilation mode which you are comfortable with is the best mode for you. So controlled mechanical ventilation is the recommended. So ventilator, we will set the tidal volume as well as the respiratory rate. How you will decide about the tidal volume and respiratory rate? As I already mentioned, the tidal volume will be start from 6 ml per kg. And accordingly, based on the PEEP or based on the P plats, plateau pressure, you will decide how much tidal volume you want to get. The P plats should be less than 27 or maximum 30, not more than that is recommended. And because you are giving a less tidal volume, the main target which will help in CO2 removal is your minute ventilation. So your tidal volume multiplied by respiratory rate will be your minute ventilation. So if you are giving less tidal volume, you have to add on respiratory rate little on higher side because along with the hypoxemia, you have to address hypercapnia as well. Oxygen will supply with the help of tidal volume and PEEP. Mainly the PEEP will help in oxygenation, but the CO2 removal will get help in the minute ventilation. But if you are decreasing the tidal volume, definitely your minute ventilation is going down. So you will compensate that minute ventilation with increasing the respiratory rate. So minute ventilation is equal to tidal volume into respiratory rate. So these are the main things. Now there is a pressure support ventilation when we will start weaning, or if you feel the patient is breathing well, then only we will give pressure support ventilation. Otherwise, we will not give pressure support ventilation for these kind of patients. Controlled mechanical ventilation with adequate sedation and paralysis is recommended. Now, how we will do a troubleshooting on ventilation with ARDS? So we will do the ABG. If there is an increase in PCO2, suppose first ABG is showing the PCO2 is high and pH is less. So that means your oxygenation is definitely getting better with your ventilation strategies, but it is not helping in CO2 clearance. So what will you do? As I already mentioned, increase the respiratory rate. You can increase the tidal volume if your P plats allow you. Otherwise, you can't. So that means you have to go up on the respiratory rate. That also we have limitation. I have given till 35 respiratory rate, but I think more than that is, I don't think the people are giving because that will not give you enough time for expiration also. Second thing is, if there is a decrease in PCO2 and high pH, which is very unusual in a ARDS case. That can happen if patient is spontaneously breathing and the work of breathing is high, respiratory rate is very high, patient is breathing with a rate of more than 40. In that situation, PCO2 will be high. But on mechanical ventilation, this is very difficult to say that this thing can arise. But still, if PCO2 is low, what you have to do is you have to decrease the respiratory rate. Now we'll see for the PO2. Definitely the PO2 is high. So how you will address this situation? Why you have put your patient on ventilation? Because of the hypoxemia. Now if you are getting low PO2, you have to target FiO2 first. And if you are on already 100%, and you can increase the PEEP. Why the PEEP is important? If on 100% FiO2 you are able to achieve a good PO2s or good PF ratio, would you like to increase the PEEP? Yes. The reason being, you cannot ventilate these patients on 100% FiO2 for a longer time. Your target should be earliest, if you can come down on 60% FiO2, that is recommended. To manage that, if you have to increase the PEEP to a certain level, yes, you can increase the PEEP. That doesn't mean that you can keep on increasing the PEEP at 10, 12, 14, 16. There is certain limit to that. How you will check that? That we will decide on the recruitment manner. So we have to find out what is optimum PEEP. There is nothing like ideal PEEP. There are people who are saying what is the ideal PEEP, ideal PEEP. There is nothing like ideal PEEP, because PEEP is different for each and every patient. That you have to decide. When patient is on ventilator, you have to see the lung compliance of that patient. You have to give a recruitment maneuver, and you decide about optimum PEEP for that patient, which you can give. That you will get the idea after recruitment. I think that will be little, just to understand that, I will give you some brief about it, but I don't think that we can go into that detail. Peak inspiratory pressure. So the peak inspiratory, if there are peak inspiratory pressure suddenly high, patient is on ventilator and there is an alarm going on. Initially, when you left the patient 30 minutes back, the patient was fine, and then the ventilator is giving alarm. There is an increased peak inspiratory pressure. First and foremost thing, you should check your airway outside the body. Like you have to check the tube, you have to check the filter, you have to check for some kink on the circuit. If there is nothing like that, then auscultate the patient. If there is any bronchospasm, that can happen. And another thing which can happen is maybe sudden pneumothorax, because you are giving very high PEEP. In that situation also, you will get peak inspiratory pressure. But first and foremost thing, check outside the body. Check for the circuit, filter, any kinking into the tube. If nothing is there, auscultate the patient. If there is no bronchospasm, if you see the air entry was fine, then get one X-ray done. Or if you have ultrasound machine bedside, you can do the ultrasound and confirm if there is a pneumothorax. If there are peak inspiratory pressures are less, suddenly less, and there is an alarm that peak inspiratory pressures are less, in that situation, you should think about disconnection little bit. Maybe some leak. First, you have to see outside the system, check if there is any leak, there is some connection loose, or fix that. Still there is a leak. Then check your cuff pressure of the tube, if there is any leak or something, or maybe some spontaneous rupture of the cuff. If that can happen, or you can address the situation, you can correct it immediately. So P-plats definitely, because of the low lung compliance. Why the compliance is low, which I already mentioned in the pathophysiology, because your interstitial space and even your alveoli are flooded with the fluid. There is a lot of edema that is giving resistance to that area, because it is becoming stiff because it is flooded with the fluid. So the compliance of that tissue will go down. Decreased lung compliance, it is not like a balloon. If you blow a balloon, it will inflate smoothly. But suppose if there is any scar or any tough rubber tissue over there, and you are trying to inflate, it will be difficult for you to inflate. That means there is a low compliance. If it is easily inflatable, that means compliance is good. If it is very difficult to inflate, the compliance is less. In that situation, the P plateau pressure, which is a reflection of that, will be high. So in that situation, you should always keep a very close watch on the P plateau pressure. If that is high, that means you need to make some changes into the ventilation. Next. Yeah, so this is a ARDS net ventilation strategy, which I already mentioned a little bit. So first, calculate the predicted body weight, then select one ventilator mode. That should be a controlled mechanical ventilation mode. Either it's a pressure control or a volume control. We usually prefer pressure control in ARDS patients. Set respiratory rate to maintain the optimum minute ventilation. The respiratory rate should not be more than 35. Aim for saturation should be 88 to 95. In that situation, your target should not be like 100%. I want to keep my patient 100% oxygenated and 100% saturation. That should not be your criteria. Your criteria should be SpO2 between 82 to 88 to 95 is good enough for that patient with the PaO2 of 55 to 80. That is the range which is recommended. Increase PEEP with the increased FiO2 according to a sliding scale, which is kind of recruitment manual. Aim for P plats is ideally 27, but maximum 30. 30, we don't recommend P plats of more than 30 because the chances of barotrauma will be very high. If necessary, decrease the tidal volume stepwise. If suppose you're ventilating with the 6 ml per kg with the respiratory rate of 35. In that situation, if your P plats are going up to 35, what will you do? You will start decreasing your tidal volume stepwise. Initially, you were ventilating with the 6 ml per kg. You will go down to 5 ml per kg and see the P plat pressure. If it is coming in the range of less than 30, it is acceptable. But still, it is high. Suppose it is 32 or 33, you can go down to 4 ml per kg and then see how this is making a change. If P plats is less than 25, you can increase the tidal volume stepwise to 1 ml per kg until the P plats is more than 25 or the tidal volume is 6. Whatever comes first, you can follow that. If your P plats pressure are more than 30, you can allow for some certain selective patients. If your tidal volume is 4 ml per kg with ideal body weight and your pH is less than 7.15, in that situation, sometime you can allow the P plats of more than 30. And there are certain conditions. Suppose there are some acute abdomen situation. There is a distended abdomen because of the pancreatitis. So there is already little pressure on the diaphragm. In that situation, you can accept little bit more P plats on these kind of situation. Tidal volume could be increased up to 8 ml for the patient with severe dyspnea if P plat maintain less than 30. So if I'm saying that tidal volume 6 ml per kg is recommended, that doesn't mean that we cannot go up. We can go up to 7, we can go up to 8, but the target should be P plats. Your limitation is P plat less than 30. If you are able to maintain P plats less than 30, even at the 8 ml per kg, no problem, you can go ahead with that. pH goal is 7.30 to 7.45, and if pH is less than 7.15, definitely this is a respiratory acidosis. That means your CO2 is high. You can consider increasing tidal volume, and you can give little bit of bicarb because 7.15 pH is not very promising situation. You can give little bicarb, but not too much of bicarb also. Next. This is a baby lung concept, which I already mentioned, which was given by the Gattinoni, Dr. Gattinoni. The term baby lung refers to small functional portion of the normally aerated lung tissue in a patient with ARDS, which I already mentioned to you. Despite the patient size, only a small part of the lung remains available for the gas exchange, comparable to the size of the lung in a small child. That is the reason which we call this as a baby lung concept. What is the key insight? Most of the lung is collapsed, consolidated, or edematous. So the very, very little part of the lung is available for the gas exchange. If we ventilate these kind of lung with a normal tidal volume, over distension of the baby lung can occur. So this explains why the low tidal volume ventilation is critical. Standard volume can harm the limited healthy lung tissue. Now, what are the clinical implications? We should avoid volutrauma by targeting the low tidal volume, that is 6 ml, and we can go down to 4 ml per kg even. Use PEEP, or after that we can go for a prone ventilation to recruit the collapsed lung areas. We can tailor the mechanical ventilation to protect the baby lung and reduce the ventilator-induced lung injury. We have already discussed that. Next. So role of PEEP, which I already mentioned that how the PEEP is helping. PEEP will help in increase in functional residual capacity because there are collapsed alveoli, so which is creating a VQ mismatch because ventilation is good in perfusion is good in that area, but ventilation is not happening because of the edematous tissue as well as the small alveoli because of the loss of surfactant. In that situation, we can the alveoli will collapse and inflate with the ventilation. In that situation, we should add some PEEP. So that will help in to avoid cyclical alveolar collapse. And it will also help in extravascular lung volume distribution. So PEEP is actually physiologically helping in ARD situation. So we can give PEEP, but based on some criteria, we should calculate the optimum PEEP. Then only we can stop that this is the optimum PEEP for this patient. We should not go beyond that. Next. So rationale for lung protective, this is kind of lung protective ventilation. So it reduces the ventilator-induced lung injury because we are targeting low tidal volume. It prevents the over-distension and repeated opening and closing by applying a PEEP. Maintain adequate oxygenation while minimizing the harm to the patient. And this is the evidence from ARDS net trial. Lower tidal volume reduce the mortality. That is the main thing. Because of that, we are following baby lung ventilation. Next. So these are the recruitment menus. I already mentioned that we will not go into the very detailed description of that, but there are few recruitment methods. So we use recruitment menus as per our comfort. I used to use this CPAP mode. What we do, we adequately sedate and paralyze the patient. We give CPAP mode. We give the pressure of 30 to 40 for 40 seconds. So we create apnea for 40 seconds with a close 40 pressure and immediately converting it to the control mode. That can be done in the pressure control ventilation as well, but unjustifiable to use the scheduled recruitment manual. So that is the situation. That is one method of the recruitment manual. Other methods are stepwise recruitment or decremental PEEP method. How you can do that? That plateau pressure and PEEP are gradually increased with the driving pressure kept constant. Why I don't want to discuss this in detail because plateau pressure, PEEP pressure, even the driving pressure, everything you have to understand about the recruitment manual. So I'm not going into the depth of it, but yes, there are methods. You can remember that there is a CPAP method in which we can give certain pressure, 40 pressure for 40 seconds. Finish. But adequately sedated and paralyzed patient. Second method is stepwise increase the PEEP. We can keep the PEEP, we can gradually go upon the PEEP as per the driving pressure, and wherever I'm getting a best lung compliance, I will stick to that. Or I can keep the PEEP high and gradually come down 2 centimeter decrement every after certain time. And after second recruitment, PEEP is set at 2 centimeter above the PEEP where I'm getting the best compliance. So you can remember two things in your mind because nobody is going to ask you in detail how you are doing it. Just CPAP method, 40 for 40 seconds, and stepwise recruitment, either increment or decrement of the PEEP. That much is more than enough to remember that. How you are doing it, nobody is going to ask. Next. Next. So second important thing, first we have discussed about fluid conservative therapy. Next is mechanical ventilation, in which we are doing a baby lung ventilation. Third most important thing is heavy sedation and neuromuscular blockage. So in these patients, we always keep our patient very heavily sedated because we do not want that patient should wake up and they should try to breathe on their own so that there will be some ventricular desynchron. We will try to manage with the deep sedation, but if it is not possible, then paralysis by the neuromuscular blockage is recommended, and that has proven a decreased mortality. But for longer neuromuscular blockage agent can create a critical illness neuromyopathy for a longer time. So we have to be very selective when we are adding neuromuscular blockage to these patients. Next. Next. So next important point is when to initiate proning. So we have given, good mechanical ventilation, baby lung ventilation, and we have given enough sedation and neuromuscular blockage, but still our hypoxemia is severe or moderate to severe. In that situation, we should try proning. So how the proning will help? That if the PF ratio is less than 150, it has proven that there is a decreased mortality. Next. So this is the diagram. So this is the picture which is showing. So first picture is showing the supine ventilation. If you see, the dependent area of the lung, which is on the posterior side, is all flooded. So, which is showing that definitely this part is not helping, not participating in the gas exchange. The area which is looking like black on the anterior side, that is a very minimum area. So that is actually participating in the gas exchange. So in that situation, so how we can improve that? Little area on the anterior side, but the posterior area is definitely not participating. In that situation, we will prone the patient. We will make the patients lie on the tummy. So in that situation, the posterior area, because this is the dependent area which initially was not getting enough gas exchange, now we are making that non-dependent area. So non-dependent area, that is a little more in volume, and if we are making a proning, that area will open up and it will start participating in the gas exchange. Now, what is the negative part of that? Whenever we are making the patient prone, we have to be very well aware about the hemodynamic stability. If your patient is hemodynamically unstable, proning a patient will create some risk of worsening of hemodynamic instability. The reason being is that your heart is coming into the anterior and your heavy lungs can compress on that area. So you have to be very, very sure that you can manage this patient in the prone, and patient is not that hemodynamic unstable. Hemodynamic instability is relative contraindication. It is not absolute contraindication for sure. So you always try proning in these kind of patients. So what will you give it, what will give you the idea that this will help or not? After trying it only. Once you are trying the prone ventilation, you have to observe the patient. If your patient is not worsening from the hemodynamic point of view, you can continue with that. The reason why I'm pushing to try this, because maybe your hemodynamic instability is because of the hypoxemia. Once your hypoxemia will start improving, your hemodynamic stability will come. So in that situation, you should always try proning. So proning is recommended and they have proven a decreased mortality in these kind of patients. Next. Now, what are the contraindications? So absolute contraindication is unstable spinal fracture or unmonitored increased ICP. These are the only absolute contraindication. Rest all are relative contraindication for proning, like open abdominal wound. You can easily cover the wound and you can make the patient prone. Multiple trauma, pregnancy, severe hemodynamic instability, severe facial trauma, and facial surgery within 15 days. I already mentioned that hemodynamic stability is a contraindication, but it's a relative contraindication. It's not an absolute contraindication. Next. Next. So this is the stepwise approach that you have tried, you have applied for the fluid conservative strategy. You have given good mechanical ventilation with a baby lung. You have given good neuromuscular blockage. Now you have tried with the proning also. Still hypoxemia is there. Still there is a refractory hypoxemia. Maybe the reason is now pulmonary hypertension also. In that situation, you can try with the inhaled pulmonary vasodilator. But how much it will help, we don't have any proven or evidence for that as of now. But yes, few people are still trying inhaled nitric oxide in these kind of patients. Why I'm putting some point on this? The reason being is when you are already out of option. You have already tried proning. Now still the hypoxemia is there. Now what is the last option for you, which is VV ECMO, that you can try with the extracorporeal membrane oxygen, which is the last resort. Although that is also there is no good trial to suggest the benefit after the VV ECMO, but yes, we have seen personally that ECMO is actually help in acute situations, not in the chronic situation for sure, but in acute situation, if the disease is less than 7 days or 10 days, we are actually seeing a good results. Now, in that situation, the inhaled pulmonary vasodilator can help to buy some time because your patient is already hypoxemic. There is a pulmonary hypertension already set in. Because of the pulmonary hypertension, again, the CVP, JVP, ascites, hepatomegaly, the other organ involvement will start. So, first and foremost thing that you have to decrease that pulmonary vascular resistant. So, you can take some help of inhaled pulmonary vasodilator so that the RV dysfunction will not set in, just to buy some time till you are ready with the PV ECMO and all logistics of the ECMO. That is the only benefit about inhaled pulmonary vasodilator. Next. So inhaled nitric oxide or the prostacyclin in ARDS, it is a selective pulmonary vasodilator. That is the most important part about it. Improve ventilation perfusion matching and oxygenation. There is a transient improvement in oxygenation, no mortality benefit shown in trial. That is the reason that this has not become a first line therapy for the ARDS. It is actually reserved for the rescue therapy in severe hypoxemia. Inhaled prostacyclin, which is a pulmonary vasodilator with the anti-inflammatory and antiplatelet properties as well. It may improve oxygenation similar to nitric oxide, but again, it is a less expensive alternative and there is a very limited evidence about the outcome benefit. So what is the main use of this inhaled nitric oxide and prostacyclin? It is considered as a bridge therapy, which I already mentioned. This is a bridge therapy while definitive measures like the prone or ECMO are arranged. But it should not delay other proven therapies. It doesn't mean that you are trying for inhaled nitric oxide as an option for the treatment. This is not an option for the treatment. This is just a bridge therapy to your definitive measures. Next. Now coming to the last resort, which is extracorporeal membrane oxygenator. Next. So VV ECMO, when there is a refractory hypoxemia, even after trial of proning and everything, still your PF ratios are less than 150 or even 100 also. So there is no good trial to suggest the benefit, but how it is helping, we will discuss about it. Next. Next. So VV ECMO, how the VV ECMO, next. So ECMO. So what is ECMO? ECMO is extracorporeal membrane oxygenator. Now, how it is helping? So first you have to understand what is the problem. There is a hypoxemia. First and foremost thing, there is a hypoxemia, and when you are trying to correct that hypoxemia, there is some permissive hypercapnia. You are also addressing to that situation, and because of the hypercapnia, there will be a low pH. Because of the hypoxemia, there is a RV dysfunction. There is a multi-organ involvement. And to stop that cycle, first you have to correct the hypoxemia. Now, how you will address that? See, you have tried everything. Your lungs are not participating in gas exchange despite all therapies like proning and this neuromuscular blockage or baby lung therapy. Everything you have tried, but still your lungs are not adequately participating on to the gas exchange. In that situation, what you have to do, what you have in your hand, you have to bypass the lung. Now, how will you bypass the lung? That you have to take a help of oxygenation from outside the body. Because inside the body only you have lung which is participating into the gas exchange, which is actually flooded now, and no proper gas exchange is happening at the tissue level. In that situation, you have take the gas exchange help from outside the body. So ECMO is extracorporeal membrane oxygenator. That means you will oxygenate the blood outside the body. How you will do it? You have to put one cannula into the femoral vein. That will be your drainage cannula. So that tip of the cannula will be at the RA-RV junction. So whatever the blood is coming into the RA, because RA is deoxygenated blood which is receiving from whole body. deoxygenated blood from RA going into the RV, and through RV it is going into the pulmonary circulation into the lung, where the gas exchange will happen, and oxygenated blood will come into the LA and then LV, and it will circulate into the blood. Now, where is the problem? Problem is at the lung level. So you are getting deoxygenated blood into the RA and RV going into the lung. Rather than going into the lung, what you are doing, we are diverting the blood from RA to outside. You are putting a cannula into the femoral, you are draining the blood out, passing into the pump. Why the pump is needed? Because of the negative pressure. You have to suck the blood outside the body. It will not flow on its own with the adequate speed. So you have to apply some negative pressure with the help of this pump, and it will pass through the console. Why the console? It will maintain the temperature. Whenever the blood will come out of the system, the blood will get cold because the temperature will be less outside the body. You have to pass on the console to maintain the temperature of the blood between 36 or 37, and then go back to the oxygenator. Now, how the oxygenator is helping? With this oxygenator, there is a membrane to that oxygenator. In that membrane, it is connected to the blender. With the blender, the oxygen supply will go into the oxygenator, and where the gas exchange will happen. There is a membrane. One side of the membrane, there is a gas, and the other side of the membrane, there is a blood flowing. So this membrane is a healthy membrane. Now, whatever the part, whatever the function the lung was doing, the gas exchange, that oxygen will come into the blood and CO2 will go into the gas part. This will happen at the membrane level. Now the oxygenated blood, you can see the blue, and then it is converting to the red because now it is oxygenated filled. Now we are returning back to the IJ. Now through IJ, where will it go? It will go to RA. Again, RA, right atrium to right ventricle, it will go into the left atrium and the left ventricle, and it will go into the system. Now what you have done? You have corrected the hypoxemia. You have given enough oxygen to the blood. Now each and every organ will get oxygenated blood, better oxygenated blood. So whatever the damage has been started, pulmonary hypertension, that increased CVP, the multi-organ involvement, everything will stop. You have break that cycle, that vicious cycle, which is ongoing. So you have to break that cycle with the help of extracorporeal membrane oxygenator. The things will start reversing. At this point of time, you have to give some rest to the lung. Next slide. So ECMO for respiratory failure. So you have tried everything. Now, what are the indications? As per the earlier criteria, there are certain indications when you will start thinking of the ECMO. When there are PF ratio less than 50 for 3 hours, continuously it is less than 50 for 3 hours, you will not wait for longer time. Despite optimization of mechanical ventilation, use of adjunctive therapy like proning, inhaled vasodilator, paralytics, everything you have tried, but your PF ratios are less than 50 for 3 hours. In that situation, you will start thinking of ECMO. If PF ratios are less than 80 for 6 hours, despite all the criteria, your arterial pH is less than 7.25 and PCO2 is more than 60 for more than 6 hours. That means you are able to achieve good oxygenation, but you are not able to remove the CO2 in this kind of lung. In that situation also, you will start thinking of ECMO. And these are the indications of ECMO. Now, what are the absolute contraindication? Actually, there is no absolute contraindication, but irrecoverable cardiopulmonary disease. If there is a, suppose ILD, interstitial lung disease, or fibrotic lung, we know these lungs will never recover. In that situation, definitely putting a ECMO is, it's not a reversible reason. It's a irreversible damage to the lung. So in this patient, if you are putting ECMO, that will be ECMO to bridge to transplant. That will not be like recovery. If you are already thinking the patient will need transplant, in that patient you can put ECMO, you can try if patient can come out of ECMO. Otherwise, that patient will go for lung transplant. Or if there is a catastrophic brain injury. In these situations, you will definitely not recommended or consider VV ECMO. But there are other relative contraindication if there is active hemorrhage or coagulopathy or contraindication to anticoagulation, if patient is immunosuppressed or bone marrow failure. Age is also a criteria that more than 70 years you will always think, because putting a patient on ECMO is not an easy job. The 7 days patient will be on ECMO, then weaning, then out, then critical illness neuromyopathy. It's a long journey. That patient will need at least 1 month of ICU stay if you are putting these patients for ECMO. So age is also a relative contraindication criteria. Mechanical ventilation more than 7 days, which I already mentioned that if it is a more than 7 days, already lungs have started converting into the fibrotic. The chances of coming out of ECMO will be very less. Expected survival less than 6 months. If suppose patient is having some malignancy or some end stage disease, and we are not expecting that patient will survive more than 6 months, then why to put all this exercise? Because definitely putting a ECMO, again 1 month of ICU stay, then hardly survive for 3-4 months doesn't make any sense. And multi-organ failure. So these, if there is already multi-organ failure setting, there is a liver injury, there is a kidney injury, and there is a coagulopathy because of all these things, definitely putting a ECMO on this patient will be very, very risky. So once you have put on patient on ECMO, now the ventilator setting will change immediately after that. Now we have tried everything. We are taking a help of extracorporeal circuit for oxygenation. So we have to set some ventilator settings after cannulation. Why? Because with the baby lung ventilation, with the high PEEP, definitely we are giving some risk to the lung. There is a ventilator-induced lung injury risk. There is a risk of barotrauma. There is a risk of volutrauma. So to avoid that, because now oxygenation is helping through the extracorporeal circuit, so we can give rest to our native lungs. So what you can do is PEEP, you can give between 10 to 15. Why? Because you want to keep the alveoli open. Otherwise, it will collapse. And then it will give you very hard time to open it up after some time. Tidal volume should be less than 4 ml per kg. So how you will decide that how much tidal volume? For ARDS, we are giving a minimum criteria of 4 ml, but in this situation, you can go even 3 ml or 2 ml. So what is the main criteria? How much tidal volume you can give? Your P plat should be less than 25. That is the main criteria. Respiratory rate between 4 to 15 and FR2 should be less than 50 because every major part of oxygenation is happening into the extracorporeal circuit. So indications for other etiology of respiratory failure may differ. Individualized ventilator settings vary based on the etiology or respiratory failure. Example, if there is a large bronchopleural fistula or tracheal injury, it may require ultra low airway pressure. So these are the indications where ARDS has not set in, but we can't ventilate the patient with the high pressure. In this situation, we can consider ECMO. And consider PEEP titration to determine optimal individualized PEEP for best compliance. Best compliance. This is the word you have to remember. Optimum PEEP and the best compliance. Next. The role of steroid. So as per the available present evidence, there is no role of evidence mortality benefit or morbidity benefit after the steroid. But still, we are practicing in few scenarios that steroid may be considered. Next. So what are the doses or what will you give in ARDS? So there is no morbidity or mortality benefit, but some situations we can consider giving a steroid. If there is an early ARDS within 24 hours, you can consider giving dexamethasone 20 milligram IV daily for 5 days, then 10 milligram daily for 5 days until extubation. For early ARDS within 72 hours, definitely if you are struggling with the PF ratio, your patient is not showing any improvement, you can consider with the methylpred with these kind of doses with the over a period of 28 days. And if there is an unresolving ARDS, which is between 7 to 21 days, we will consider giving high dose of methylprednisolone. Why? Because already our lungs must have started converting into the fibrotic changes. So in that situation, the dose of methylpred will be high. And we will continue till 32 days or even if extubated before 14 days, we can advance for 15 days of regimen therapy. So almost 1 month of steroid will be given. But as per evidence, there is no morbidity and mortality benefit. We are just trying to protect some inflammatory changes happening into the lung with the help of steroid. Next. Thank you. I think this is the last slide. Thank you. Do we have
Excellent. A very excellent
anyone
presentation
awake?
by Dr. Priteema.
Thank you. I just try to cut short and simplify, but I
Yes, ma'am.
still not sure.
Right. Right. I'm sure our attendees had taken the notes, and if you follow all these things in your daily life practices, you will be a very highly appreciated value for your institution, for your patient, and you can provide the best of the care to your ARDS patients. Now, I will invite for any question. If any of our attendees have any sort of question, any query, can raise hands. I guess things are pretty much clear as water, ma'am. So thanks a lot again. And
Yeah.
it's a nice session, ma'am.